Um, what I'm going to be doing is a three-part review. Firstly, I want to get into a little bit of the history, or to give a context to the coordinated entry process. In other words, why it's important, how it came about. Two, I want to talk about the evolution of the tool itself, the tool that we're using. And three, I'm going to go into a little bit about trauma-informed care, to a small extent, motivational interviewing, but really the focus is related to how to best utilize the tool in our practice, the tool that we're using, which is based on something called the Arizona matrix. Now, I've been doing this work for quite some time. It goes back to the 80s. I'm going to give you a bit of a homeless outreach perspective on this, because that's what I am at heart, is an outreach worker. And I do run some programs now and do provide supervision and leadership with Elliott CHS and Homeless Outreach Services, the PATH program. And we're also doing some CSPEC work, which is housing stabilization. So I started out in New York City in the 80s, and from there I went over to Boston throughout most of the 90s. And then as we got to a new era into 2000 and beyond, I was in Western Mass for the last 20 years. And I got to say, through the 80s and the 90s, I experienced this great frustration that I bet many of you still experience from time to time today. And that is that we would have folks that were meeting out on the streets or in our programs, or wherever it is that we'd connect with someone, places not meant for habitation. And the folks we were meeting were highly vulnerable. And you know what? Most of those folks in those first meetings were not raising their hands and asking for treatment. So there was an issue of, you had people that we would say was kind of in this pre-contemplative stage, and yet they were so vulnerable that we'd say to ourselves, how can we get them housed quickly? How do we get the most vulnerable housed off the streets, get them safe? And the issue is, these folks, this particular group, was deemed at the time as not ready to be housed, if you can imagine that. And so if you think back to the 80s and that time period, much of what was being done was based on a staircase model to care. That meant you would graduate from one program to the other, and you would actually gain entrance into the program by agreeing to treatment. You'd be compliant on medications if they were prescribed, perhaps for psychiatric reasons. You would show that you could be sober before being able to enter a program. And that's not to say that as outreach workers, we weren't still doing some good stuff in terms of getting people into, let's say, single room occupancy settings and doing our own follow-up. But there was no real program that would take these highly vulnerable people that needed support. So it's all about housing plus supports. But we couldn't find it outside of building our own kind of match to rooming houses, and then the outreach people following up. And you know what? That took up a lot of our time, and then we ended up doing less outreach. So that started to change in the 1990s. Dr. Sam Semberis came on the scene. He was doing outreach in some of the very streets where I was doing outreach in New York City. And he said, you know, we need to do something different here. And he developed what's called the Pathways to Housing model. It was really the first time we started talking about housing first in the early 90s. And he's considered the father of housing first. Now, like I said, we were already doing some of this work in the 80s, but he formalized it. He added a research component, and he said, you know what, we're going to have some really good support services. He set up ACT teams, assertive community treatment teams, that were very intensive if needed, but also very flexible. So in other words, people didn't have to agree right away to work extensively with the workers. And there was a very low barrier kind of housing process. That's why it was housing first. And you didn't have to be in treatment, no longer treatment first. Around that same time, HUD started to embrace this idea of safe havens, which to me, I would say is another type of housing first that came on the market for us to be able to use and get funded. And the safe haven was meant as a small shelter where people who were out on the streets with major mental illness and could not access shelters, right? Because there was a lot of trauma, a lot of layered trauma, compound trauma, people going to shelters and being triggered and taking off. And, you know, it's the same old story, right? I know you're coming across a lot of this today. Well, anyways, the Safe Havens was brand new and it was very exciting to our outreach teams because all of a sudden around 1992, 93, these programs got set up and we could place people into them without them having to be in treatment. And so that was a really great step forward. Now, the next big thing that happened that was very exciting is, and this came out of Massachusetts, and I knew the gentleman, his name was Phil Mangano, because now I was in the Boston area, and Phil Mangano was the head of Mahasa. And he started really talking about that we have to end homelessness and housing first is the way to do it. He really was that rallying cry. It came from Phil Mangano. He got appointed to the Bush administration and actually nationally started pounding the pavement, going from COC to COC and saying, what's your 10-year plan to end homelessness? So HUD is financing these COCs. We got these new models on the ground, a little bit of housing first that's happening, the safe havens, and now the COCs are being asked to come up with 10-year plans. Well, you know what happened with that? It was good in that it coordinated things a little more. We got our resources together, but then we got into like the 15th year of the 10-year plan, and that was a little bit deflating. You know, we still had homelessness and things weren't moving quite in the directions that we wanted. So now I'm going to get to this slide right here about the vulnerability index, and that is around the late 90s, with that being the context of what's been going on, we had this guy, again, a local person in Massachusetts, so be proud to be part of the Commonwealth here, Dr. James O'Connell. A lot of people wanted to nominate this guy for sainthood. I mean, he was like really someone who was amazing in terms of being a street medicine physician, heading up healthcare for the homeless. Still go back to that first slide. And the vulnerability index was introduced based on his research. And what James O'Connell found, and this was really important in terms of his research, was that there were certain categories that if people fell into, they were at high risk of death. And that first category that you can see on the screen here is if you were outside 6 months or more, and that's going to be for all the categories, you're outside sleeping rough 6 months or more, and if you had more than 3 hospitalizations or emergency visits in a year, you were at high risk of death. If you were had 3 emergency room visits in the previous 3 months, more than that, you were at high risk of death. If you were age 60 and older, again, outside 6 months or more, you were at high risk of death. If you had a variety of medical conditions, cirrhosis of the liver, end-stage renal disease, HIV/AIDS, or even just a history of frostbite, immersion foot, what I call trench foot, or hypothermia, if you had any of those things, or at risk of those things, in other words, you've had them in the past, but not currently, you are at high risk of death. And lastly, and so many of the people we meet fall into this category, if you're trimorbid and living outside, in other words, you have a psychological or mental health concern, you have on top of that medical concerns and addiction. If you have all 3 outside 6 months or more, high risk of death. What that means is 40% of the folks that fell into these categories died prematurely. And they died within 5 years at the age of 47, well, the average age of 47 years old. If you take away that category of 60 and above, the rest averaged 47. So now we can go to the next slide. So what James O'Connell was basically saying through this research, and this is really the first vulnerability index that became very popularized in homeless circles, and the outreach workers were using it to help prioritize our work on who to help, who needed our help, who was most vulnerable. And he said, you know, we should look at housing kind of on the level like we looked at giving out a script, right? Because housing is a social determinant to better health. That's very important. Stable housing can equal better health. I remember back in the 1980s, we would rally and we'd be screaming, you know, housing is treatment. And this really sets the table for the good work that we can do in the housing stabilization services. And they begin to melt what I call that pre-contemplative iceberg as we provide the supports to help build those pathways to treatment and recovery. Now, Dr. James O'Connell also did, and so did many others, studies on what happens when folks get housed and the difference in terms of high-end utilization. So the housing, in Housing First, what it did is it also reduced costs. He found in a 5-year study, this was done in 2005, so we're getting a little closer to the present now, of 119 chronically homeless street folks out in the Boston area. Over that 5-year period, there was 18,384 ER visits for the people that were sleeping rough or chronically homeless street dwellers, 871 hospitalizations. So we can go to the next slide. If you break down that yearly cost, we're looking at close to $30,000 per person on average of the folks that were living outside versus for a similar cohort where you're doing Housing First, it was about $6,000 per person. Well, guess how much it costs for a Housing First bed? It's around $15,000, and you can do a support service and house someone and pay for the subsidy for that housing for about $15,000 annually. So in other words, we can save money and house people by using this model, as well as save lives and have better health. So lastly, I'll get into, before we go on to the last part that I'm going to get into, which is around talking about the actual tool and what we're doing, and also talking about trauma-informed care, is that trauma and homelessness is linked at the hip. Now, that's a very important thing to understand, that we're meeting so many people that when you kind of look at their situations, they're presenting with compound trauma. In other words, there's histories from foster care, childhood abuse and neglect, people who have experienced domestic violence, and then think of what you go through in terms of trauma and just becoming homeless. And think of after you're homeless, the types of situations you may be in, perhaps very violent situations that you either witness or have happen very directly. We can go to that next slide. That's okay. So as a result, we said to ourselves, what are we going to do? We have high levels of trauma. We have premature death. We have high financial costs, as well as the quality of life issues, right? For both the communities we're in and the people we're serving. And so that's where we really got to the point we are now with coordinated entry as being kind of the strategic Housing First, systems level Housing First answer, and to connect people into housing who are most vulnerable as quickly as possible. Well, we needed a tool to do that. And that was to prioritize people on our by name lists that Kelly had talked about earlier. And so the first tool that was being used, like really nationally, like a lot of COCs were using this tool, was the Vulnerability Index, otherwise known as the VI-SPDAT, Vulnerability Index Service Prioritization Decision Assistance Tool. Wow, that's a mouthful. And so here we have some sample questions from the tool that I'd like you all to just read and kind of take them in and like what these questions are about. And to be thinking, I'm going to give you two important numbers. One is, when they gave guidance on how to do this tool, they said you can do it in 7 minutes. 7 minutes, think about that. And the length of the tool was 40 questions. So in 7 minutes, 40 questions, and we were told volunteers could meet up with folks who are homeless in the community, Meet these folks for the first time and do this tool. And here's a sample, 7, 8, and 9, of the very questions on the tool. So just take a minute, think about the questions, review them in your mind, and ask yourself, do you think you would get an accurate answer to these questions? And in a moment, I'm going to ask you why or why not. So question 7, do you have any legal stuff going on right now that may result in you being locked up, having to pay fines, or make it more difficult to rent a place to live? So if you're doing outreach, you're meeting someone for the first time, they're outside on the street, you ask them that question, do you think you get an honest answer? What do folks think?
Absolutely not.
And why do you think not?
So first of all, I mean, folks that are living on the street and would be, subject to this sort of assessment are obviously in survival mode. And so the answers to these questions are oftentimes going to be yes. And you're typically, as a service provider, coming on as a stranger. And even though you are coming to them saying, I want to help you, I want to support you, and we'd like to get you housed, that's possible. They're still going to be questioning whether or not that is the reason that you're there. So I think that that's one level of challenge in getting those questions answered accurately.
Mm-hmm. Mm-hmm. And then if you go to number 8, does anyone force or trick you to do things that you don't want to do? And by the way, on 7, I just want to mention, also think about racial equity and think about the racial context of if you're a white outreach worker meeting someone who's a person of color, and you're asking them if they've been locked up, having to pay fines, and they don't know you, how also that might be another reason that person might be hesitant to share with you. Because sometimes people are thinking, I want to give the right answer or the answer to be upheld in some way. They don't know really how you're scoring this tool, right? Actually, if people say that they do have legal stuff going on, they actually get a score that bits them higher for housing. So does anyone force or trick you to do things that otherwise you do not want to do? And we'll also go to question 9. Do you ever do things that may be considered to be too risky, like exchange sex for money, run drugs for someone, have unprotected sex with someone you don't know, share a needle or anything like that? How do you think folks might react or respond to those kinds of questions?
So you haven't developed a relationship with these people, right? You're going up to them and you're asking them very personal questions about themselves.
That's correct, yeah.
Number 8, where you're asking if people have manipulated or tricked them. Being homeless is definitely about survival, and they have to learn a different way and they have had to learn a different way. So they've been tricked and manipulated many, many times. So why would they trust somebody coming up to them with a questionnaire, especially when it's not going to take 7 minutes to answer all the questions? That in itself is a lie,
Right.
or a trick. So you've already blown it. As far as I'm concerned, and asking these personal questions to somebody you don't know and they don't know you.
Exactly. So what's happening is this is actually starting to get in the way of our relationship building process. And it's not particularly trauma informed, is it? If we think about it, it might be actually putting people into very anxious states, triggering memories of maybe very negative things that happened to them. And they're not in a place where we can even provide a safe place for them. So in some ways, I would argue it's quite irresponsible to go out on the streets, ask these questions, disappear later, even if you're doing it in a program and the person can't stay there and they're off, because there's also different levels of trust, and there's different times when people might be more ready to contemplate these types of questions. But none of that was really being considered with this VI SPDAT tool and the way it was being organized and done. So what we did is we rejected using this tool, which I got to say, a couple of years ago was a brave thing to do, because there was a lot of pressure coming down. Everyone should be using this VI SPDAT. This is what all the COCs are adopting. And we said no. We didn't think it was trauma informed. We thought it was a lot of work, actually, in terms of the number of questions to have to do and ask. And we thought it wasn't fair, to the clients and that we wouldn't get good answers, so that the tool would not be both, reliable in terms of its use. It's going to depend on your relationship with the person, the type of answers you might get, and not valid, because people have all sorts of motives as to why they might give certain answers depending on who's interviewing and what they think is going on. So let's go on to the next slide. So what we wanted to go toward, like I said, is doing something that's much more trauma informed. And so I want to talk a little bit about trauma informed care, and then how this kind of connects to the work that we're doing with the current tool. So there's 4 basic tenets to trauma informed care. So I'm not getting to the principles just yet. The tenets is that we do a trauma education for everyone. If there's a community that we're working with, it's trauma education, but for the staff certainly, but also for the people, the clients, the participants. And there's different ways to do that on different levels, right? In individual and group, having these kinds of forums now, for staff to attend. But for people to understand the effects of trauma and how that's very important in terms of us getting a safe community for people to be and have patience with each other, and to build that sense of mutuality and trust. The second tenet is to promote safety. And this could be on a level of safety planning individually with people, but it's really a lot about relationships. It's about that people are there and they're welcoming, and there's not like some other agenda going on, and that you're really there as a resource, and we're non-judgmental. And so we're looking at both the environment being safe, perhaps not too overstimulating, developing safe spaces. So there's physical environment concerns, but there's also social environment concerns toward promoting safety. Third, we want to rebuild a sense of control. If you've been through a lot of trauma and layered trauma, compound trauma, you've lost so much control in your life. It was taken away, that sense of control, from these traumatic events that occurred. So to rebuild control, it's our job to respect autonomy and to give choice to people, and to really meet them where they're at and go at the pace of the person. And again, very relationship focused kind of work, person-centered work. Fourth is strength-based work, very, very important in terms of working and appreciating people's current level of skills, the ability to adapt, the point that they've already survived trauma, that some folks have actually been quite resilient to homelessness and getting by, understanding people's interests, thinking about how are they coping and adapting already, and how can we enhance that? Can we help people to enhance their coping skills? And you can see how all of these tenets really directly connect to these 6 principles. Safety, we already talked about some. Trustworthiness and transparency. Again, it's really about the relationship and the that we're there in terms of building trust, but also around things like the basic policies and the rules that's in a program, and to the degree that's explained, and that the person can have some voice in regard to these rules and policies, and that these rules and policies also apply to everyone in the community, not just the participants. Peer support. How many of you, maybe just by a quick raise of hands, or just think about this, do you have peers that either are part of your staff that are working with you, or do you have maybe people within the community that you serve, serving kind of that peer role, or are you let's say, encouraging partnerships, encouraging support systems among people that you're serving. Do you ever raise the hands on that? Peer support? How many people find that important? I know in PATH we have that as part of our model of the work we do. Collaboration and mutuality, you know, the idea that we want to get away from staff silos and we want to encourage that people are kind of all in this together. So again, it talks about safety and being trustworthy, empowerment and voice and choice. I talked about autonomy, reaching out to the people that are quiet and encouraging them in different ways to give feedback to what's going on around them, empowerment to bring back that sense of control. And, you know, where do you allow people to speak up, to give voice? Can you do it in your one-on-one meetings? Can you do it through a suggestion box? Do you do it through small groups? And lastly, and very important, is cultural, historic, and gender considerations. In other words, we're rejecting stereotypes, and we're all about really getting to the point of having both a diverse and inclusive community. And we do that in terms of our practice, in terms of our welcoming, in terms of not being judgmental, but also I think in terms of the way we talk about rules and policies and all folks being welcomed. Now, when folks have been through trauma, one of the things that can happen is they can be triggered. And when people get triggered and they're re-experiencing trauma on some level, or their body is letting them know that this is not a safe situation. They're not feeling safe. We're not upholding these types of tenets and principles in our work, or for whatever reason, there's some sort of situation that plays out that triggers the person, even if we're doing great work within the environment they're in, because a lot of these environments are uncontrolled, so to one degree or another. What happens is we start to see this response that's along the lines of a fight, flight, freeze response. And when that's happening, what you're getting is this primary impulse kind of response that's going on. And it's really not engaging what I would call, or others would call when we talk about the brain, the prefrontal cortex and this kind of higher secondary, let's say, level of thinking where you still experience emotions, but you have more meaning to them, but you're not overwhelmed by emotions and you're not reflexively going into a fight, flight, freeze frame. So the way this connects to the tool, and this is very important, is we want to set the table to use the tool with people, and we want our timing to be right, and it should be relationship based on the folks that we know, that we've already developed some trust, and that when we present the tool, it makes some sort of sense in the person's world. It has a meaning that it's about our journey together toward helping the person. It has a meaning that we're talking about that you might have some goals around getting housed. And this is a way to go about that. Now, this is not going to solve that by itself, and we have to be very, very transparent about this, that there's not a lot of housing options through the by name list, but there are some. So if we can get you on that by name list, that might come through. But you want to say to the person, we're also going to work on other housing options for you, other situations to try to get you to a better place. But we should be speaking to the person in regard to their goals, their aspirations, and engaging them not at a point where they're in a panic, not at the point where they're really angry and making these offerings, but at a point where people are calmer and engaged, that prefrontal cortex, the relationship is working, the sense of safety is there, there's some sense of privacy and work that we're doing together that's mutual. There's a common language that has been developed. And within that frame, we might then begin to explore the questions. But the tool that we're using is different than the VI SPDAT. What this tool is it's based on something that's called an Arizona matrix. So it is a not a client survey, but actually it's the staff that's being surveyed as to the level of the client functioning or the participants functioning. Now that's very important, because if you know the person well, if you're already doing your intakes and getting to know the person in your programs, you already are going to know the answers, the ratings that you can put down to a number of these questions. And so you don't have to ask these questions that are going to get people very anxious. And if you do have to ask questions because you don't know the rating, you're going to set the table the way I'm talking about it to kind of delve a little bit further in a gentle way. So there'll be some questions that you might need to consider and then interview the person to get some more answers to. But there's other questions that you're already going to know the answers because they've already been working with you for a period of time. When we roll out this tool, it's not at first meeting usually. It's at a point where the worker that knows the person's best is the one we'd like to be doing the tool when that's possible. And again, it's an offering, it's a contract. You go from engagement, trust, right? And pre-engagement, just getting to the point of a welcoming communication, building trust where you have some ongoing communications and meetings. The work is starting to unfold with some basic sets of goals. And within that, you can offer getting people on the by name list. And within that frame, if you need to, you can talk about the tool and a couple questions you want to ask just to get them prioritized on the by name list. So I hope in general that's helpful. That's kind of the setup before we actually go over the tool itself. And I want to mention, just to end on my end, is 3 books that I think might be helpful for people to consider in the future. The first is Trauma and Recovery by Judith Herman. This is an amazing book, and Judith Herman, I got to say, you know, she really led the world, you know, in terms of trauma and recovery work. And she was doing this before, obviously, the whole trauma-informed care movement even got started. Was doing some great work with families, with children, with people in the military, and talking about the stages that we go through toward recovery from trauma. And the first stage, by the way, is safety, is promoting safety and being able to manage those triggers. The second book I'm going to mention is Connecting Paradigms by Matt Bennett. This is an excellent book if you really want to get into the connection of trauma-informed in a neurobiological framework for motivational interviewing. So he really goes into a lot of the brain stuff and the body stuff in this in regard to how that connects with trauma. And then motivational interviewing is integrated into his model. And then the last book I'm going to mention quickly is one I recently did called Cross-Cultural Dialogues on Homelessness. This was a joint project with folks in the UK. And in the UK, they talk about psychologically informed environments. And a lot of the work on trauma in regard to psychologically informed environments came directly out of people's experiences in shelters and their inability to serve people that were walking into these shelters that they considered were having like traumatized personalities and being having trouble following the rules and being kicked out and not being helped. And so they came up with this idea of psychologically informed environments. And then they utilized the pre-treatment model that I talk about from my work as one of many, but one of the psychological approaches toward helping folks in a trauma-informed way. Thank you very much.
Thanks, Dan.